Hi, I'm Dr. Jared Gardner. I am here today with my awesome pathology resident, Dr. Fatima Absar, and she's been doing soft tissue with me this month, so she's helped me put together some cases here to make a video for all of you at home. So thank you, Fatima. So this case here, we've got a shape biopsy. What do you think about this?
My first glance from low power would be a DF.
Uh-huh.
But this colorate, it's not typical of a DF.
Good. Yeah, that's a great example of a collarette. We can see at low power, the epidermis basically, this is a lesion that is pushed up at the very top of the dermis, pushing into the epidermis above it, so much that the epidermis is reaching down around it to try to grab it. And you can actually see, depending on the angle of cut, that's what it looks like kind of at the peripheral edge, right? As we cut back into it, those two arms actually connect kind of at the outer edge. So this is like kind of a, an oval egg-shaped thing that's so pushed up so far that the epidermis has almost pinched it all the way off, kind of is the way I think of it. And that's a useful feature because it is a common thing in a handful of different entities and not something you see very often in a lot of other entities. So it can be really helpful that alone. So like you said, you don't usually see that in regular dermatofibromas, right? So what kind of thing might you see that in that you'd be thinking about here?
These cells are more epithelioid.
They are, yep.
And one of the entities where this is characteristics is an epithelioid fibrous histiocytoma.
Yeah, very good. Epithelioid FH or epithelioid fibrous histiocytoma, or in my opinion, at least, I think these are the same thing that's been described also under the name epithelioid cell histiocytoma. In the past, some people published them as that. And it's an interesting entity, I think, for several reasons. It's a particularly interesting entity to me because these are kind of a benign, unusual lesion. So it's nice they're benign and kind of cool to look at, and they don't hurt the patient, which is great. So when you can arrive at the diagnosis of this, it's great because you're like, I've got a name to put on this, and we know that these behave indolently, at least from our knowledge so far. The other reason it's interesting to me is that, since the time I was in training till now, our knowledge of what these are has evolved a good bit. So in training, my concept was that these are like an epithelioid variation of dermatofibroma, which is also known as benign fibrous histiocytoma. And the name fibrous histiocytoma is problematic, right? Because it's in so many different soft tissue entities, many of which are unrelated. But the thought is maybe these were weird epithelioid variants of dermatofibroma. But even from when I was a fellow, that idea didn't sit particularly well with me, just because it's so unusual. Why is the collarette there? Epithelioid plump cells we can see in a DF, but why is there this collarette? Why is the lesion very nice and sharply circumscribed? DFs usually are not sharply circumscribed. They trickle into the dermis and wrap around collagen, but these lesions usually are very sharply circumscribed and well demarcated, where you can see exactly where the lesion ends and the dermis begins. I feel like that's the majority of these that I've seen. That's very characteristic, even if they don't have a collarette. And then the cytology is different. And the other thing that's a little unusual is that these can express, I think it's almost 50% in some studies, EMA, epithelial membrane antigen. So EMA isn't, I don't know why they express that, but that's a weird thing because that's not something you think of as a dermatofibroma marker. So it always seemed kind of strange to me that there were several things about this that were very different from regular dermatofibroma. But I remember signing out a few reports early in practice, saying, well, we think these are variants of dermatofibroma. But then some new information came from Jason Hornick and colleagues, and they published, I think they were the first ones to publish, I believe it was with Leona Doyle, I believe was the first author on that paper, and they published that these are ALK positive, ALK-1, ALK anaplastic lymphoma kinase, ALK-1 positive in like 88, I think, %. Like, so, the vast majority of the lesions were positive for that. And we now know that these have a variety of different ALK fusions with various different partner genes that are present. So it's added to the growing list of different human neoplasia that have ALK rearrangements. And in the skin, there's not a lot of things that have ALK, right? So it's really helpful that when you see this and you think of it, and then you've got ALK, well, that's pretty good. The things to rule out, the main things I can think of in the skin that have ALK, spitzoid lesions, right? Spitzoid neoplasms, and in the range between both Spitz nevi or atypical Spitz nevi and Spitz melanomas. Both the malignant benign and the kind of gray zone ones can have ALK positivity. So if you're having these, usually when I have one of these, I will usually do a SOX or an S100 just to make sure that I've excluded melanocytic, because it's be a totally different approach there. And then very rarely, when we have anaplastic large cell lymphoma in the skin, the cutaneous type usually does not have ALK, as opposed to the systemic nodal type, which usually is ALK. So those are two things called anaplastic large cell lymphoma, which are basically unrelated. They look similar, but they're unrelated. So that's a topic for a whole different video. But it's extremely rarely the systemic ALCLs can involve the skin. I have never seen an ALK positive systemic ALCL in the skin personally, but I believe it has been reported to happen. So there are those rare exceptions. Inflammatory myofibroblastic tumors can have oftentimes have ALK rearrangements, although in my experience those are quite rare in the skin. I've seen like a couple ever, much more often to be inside the body. And I may be forgetting something else, but those are the top ones that kind of come to mind. So it's nice to be able to find this. So in any case, what I see when I see this lesion with the collarette, then I see it's sharply circumscribed. I see that there's these big plump epithelioid cells. And this is the reason, again, that it's good to recognize, because, otherwise you might start thinking all sorts of other stuff for this. The reticulohistiocytoma can have cells that are very big and epithelioid like this, and sometimes those, when they're multifocal, are associated with arthritis and sometimes neoplasia and other things like that. You could start thinking of melanoma or melanocytic things. You could think a little of epithelioid sarcoma maybe. You could think of a variety of other things, right? These big, plump, almost some of them are kind of rhabdoid looking. But so once you arrive at the diagnosis of epithelioid FH, then suddenly, oh, it's okay now. So this is like to me, like a real nice classic one with a big epithelioid cells. The other things that they have oftentimes is they tend to have pretty dense collagen in the background. We can see it better. It's kind of sclerotic, hyalinized, really dense pink background in between the cells. And sometimes the cells are more in kind of diffuse sheets like we saw over here. And other times they're kind of embedded as single cells within this dense collagen kind of background. And then look at the dilated vessels. The dilated vessels I find to be pretty helpful. I would say the majority of cases I've seen have these very big ectatic vessels with the sclerotic collagen, and then with the plump epithelioid cells, and then sharply circumscribed, and usually with a collarette. So epithelioid fibrous histiocytoma, and usually when I diagnose these, I add a comment that these are benign lesions that are usually associated with ALK fusion, and that they are unrelated to actual benign fibrous histiocytoma / dermatofibroma. All right, let me show you a couple of variations on this, because over time the other thing I've recognized is that I think that this entity has a wider range of morphologic features than I previously appreciated. So let's look at a couple other examples to get a feel for the range here. Oh, that one's got a scratched cover slip. Let's see if I can find a better section. That'll do.
The vessels are really prominent.
Yeah, you're right. The vessels are very prominent in this one. And this one, even though it is pushed up, it doesn't really have the collarette, right? It's making more of a kind of a polypoid papule without, at least if there's a collarette, there could be, I guess, deeper down that we're just not seeing on this biopsy, but it doesn't stand out. But look again how sharply demarcated, like that is the edge of the lesion right there. No question about it, right? It just is completely on its own, separate from the background dermis. And the dilated vessels, the dense collagen, look at that. So once you've seen a few of them, they have a pretty distinct look. But again, there have been some that I've seen that looked a little funny, and it was only once I thought maybe it could be, and then I did the ALK and it was positive, and I was very happy that I was able to figure out the case. Again, with the plump cells, some are kind of plasmacytoid to rhabdoid. Sometimes they're spindled. There's a mitosis in there. You can see some mitoses occasionally. And this one has a little tiny baby hair follicle over it. I think that's just a little coincidence there. Or maybe a bit of like kind of follicular induction, which can happen over DFs, but can happen over a variety of other lesions too. So that's another variation of it. Let's see what else. Oh yeah, this one has the collarette, but it's been ulcerated. It's been, picked at. But this one also has very plump cells, and the cytoplasm is kind of more eosinophilic in this particular case. But again, the dilated vessels are there, right? guess I didn't clean that well enough. It's got like half a collarette on this one. This one pushes down a little bit further, and I have actually now seen several that were like formed nodules that pushed way down into the reticular dermis. So that I remember when I first saw that, that kind of surprised me because all the other ones I'd seen were up very superficial, but I've seen some that made nodules that pushed way down, and I've actually, like I saw one on like the toe once that made nodules pushing all the way down to right next to bone. Really surprised me, and it was actually only, like I remember I was on my way out of town and I thought, maybe I'll do an ALK just in case. And my colleague sent me a picture and she's like, look what's positive, and it was ALK, and I couldn't believe it. So it's one of the ones that really stretched my imagination of what can happen. This was a good one too because there are some epithelioid cells, but there's also kind of a more spindly look in some areas, right? So I feel like even though the name says epithelioid, I've certainly seen a handful of examples that were quite spindly and kind of story form and really didn't look very epithelioid or had just some epithelioid, but the other cells were much more spindled. I mean, for sure, this actually looks, if you gave me that picture, that would look fine for a regular dermatofibroma, right? But then this one had the ALK, so. And then what about this? This is weird. This is pushed up into the, right below the epidermis. You can just barely see the collarette there. It's got the vessels. But then when you get closer, what is going on with the cells? They've got like all these vacuoles, like kind of like almost look like little tiny fat cells or something. They're very vacuolated. And where you do see intact cytoplasm, it has a frothy, foamy, or even in some areas, I thought it looked even a little granular in appearance. I actually even thought about maybe a granular cell tumor in some areas, but this ended up being negative for S100, positive for ALK. We may have even done a vascular marker on it just to be sure. And so I thought this was pretty wild that it's got these vacuoles and this foamy to granular cytoplasm. All the other stuff here was good for epithelioid FH, but I had never seen, and I don't think I've seen another one quite like this since. I have seen at least another one, aside from this, that was very granular, that had areas that looked very much like granular cell tumor, but the architecture wasn't right, and then the ALK was able to resolve that for us too. And I do imagine there will be more entities in the future that come out that we discover that have ALK. So continue to stay up with the literature if you're watching this at home, and you too, of course, Fatima and myself, to keep up with any new entities, because I suspect that people will continue to find more things. But I think it's a good entity to be aware of, and one that's benign and interesting. And there have been some that have been reported to actually have. I don't have an example handy, but I'll put it back here while I'm talking so people can look at that. That some have had chondroblastoma-like areas in them, and the group from, I think, Cleveland Clinic and Mayo and some others, I think, collaborated together to describe that a few years ago, if I recall. And that's pretty cool. So they have these areas that look like kind of the bean-shaped cells and the little bit of a lace-like osteoid like you see, or calcification, chicken wire calcification like you see in a chondroblastoma of bone. And I've now seen one or two of those, and I've seen a couple that actually had like kind of well-formed bone and cartilage. So again, the range of features that I see in these, it continues to expand the more of them I look. So now if I even think about it, I do the ALK. All right. Now let's see this. We'll get it turned right side up here. What is this thing?
That looks like, I would say, a typical dermatofibroma.
Yeah, good. This is a like conventional, regular, very conventional looking DF from low power. The first thing I notice is the epidermis. Look at that. The epidermis gets very thick and acanthotic. Here's like the normal. And then as you go to the middle, thicker, longer, reedy. So it's got acanthosis or hyperplasia of the epidermis with the flattening of the reedy. The reedy are tabled. Tables and chairs is what my former fellow Gina Johnson liked to say about these. She's like, it's tables and chairs, which I thought was fun. But you do tend to get epidermal hyperplasia over DFs. They often are flat. Like it's like, I think they like hit a force field. Like they come down towards the DF and then like it's like they hit an invisible force field and they stop. and that squishes them and flattens them out on the bottom. Although if you pick at, as I think we discussed earlier this month, if you pick and scratch at your DF, it will push all the way up and make the epidermis really thin over it. And people love to talk about Gren's zone, that little zone of normal between the epidermis and a dermal lesion. I don't find that concept very helpful for many lesions, although there's one right there. Look, there's a Gren's. So if you want a Gren's, there it is. But it's a concept I don't, people who watch my channel may notice that I never talk about it just because I usually don't find it useful except for a select few things. And when you irritate a dermatofibroma, I feel like that Gren's tends to disappear and the epidermis gets atrophic. And then look at the collagen trapping. Wow, that's amazing, right? The collagen from the background dermis gets kind of squished and trapped in here into the dermatofibroma cells. And this is a variant of DF here, actually. It's got kind of an unusual combo of things. It's got really dense hyalinized collagen that forms these like little rings and arcs and curlicues around the individual cells. And then look at the cells. Many of them are very foamy, see? Very foamy and like almost xanthoma looking. If you just had a high power of this, you might think of xanthoma. Although if you have a high power of this, the xanthomatous cells plus the sclerotic collagen in the background, actually I would think it's probably a DF, not a xanthoma. Xanthomas don't tend to have that I've seen at least. So this is a DF from a certain part of the body usually. DFs that have this abundant foamy cytoplasm. You can have a little foamy cytoplasm in any sort of DF, but when you got tons of it to the point that it looks like a xanthoma, and it's got this hyalinized, sclerotic, almost basement membrane looking collagen, this is called a lipidized dermatofibroma, also kind of colloquially referred to as an ankle type, because they usually arise on the lower leg near the ankle. I don't know exactly why that is, but we do tend to see, if you see a bunch of foam and a bunch of this funny arcs and rings of collagen, those are usually dermatofibromas from near the ankle or the lower leg. And you, sometimes the cells are big in dermatofibroma. Look how big and plump those guys are. Once you get to dermatofibroma, you can accept quite a lot of weirdness in the nuclei. The big, large guys that look like little eyeballs there, scattered pleomorphic cells, scattered mitoses. None of those things bother me for dermatofibroma by themselves, okay? So this is a good dermatofibroma, a lipidized type, and I've got a whole video on DF and a whole video on lipidized DF on my channel, so you can go watch if you want more example of this. And oh, look, a bonus. What's that?
Tattooing.
Yes, tattoo pigments or ink, whatever name you like. It's black, right? And black is not made by the human body. Black is exogenous always. So all the colors our body makes, brown, green, yellow, red, that's fine, but not black. And sometimes it'll polarize. I think it depends on case to case, and it usually doesn't all polarize. So I've noticed that sometimes you get little speckles of polarizing in there, and sometimes you don't. So I suspect that there's different brands and compositions of the pigment. I think the last time I read, a lot of the black pigments at least are carbon-based pigment. And pencil tattoo, graphite tattoo can look similar, although I think it's bigger and chunkier, and there tends to be little bits of polarizable stuff in there. So that looks black to me, but sometimes it's hard for me to tell, but the green can look kind of black. When you see like red and yellow, those usually you can tell they have a very different looking color. So this person right in the middle of their tattoo got a big old DF. All right, there you go. Large dermatofibromas. And those people, I mean, it's like almost down to fascia. Look, that's fascia. Oh, look at the ramen noodle sign of another former fellow, Ed Fulton, who loved to talk about how this looked like ramen noodles straight out of the package, or instant noodles if you live in a different part of the world where they call them that. And it's true. When you see that wavy, that's not nerve. That's dense regular connective tissue, collagen, okay? Tendon, fascia, or ligament. Very cool. I love the ramen noodle sign. So anyway, we've talked about that dermatofibroma to death. Now let's look at this. Can never get it the right way up. There we go. The stain and fixation is a little bit weird in the middle, so it makes it kind of a very purpley violet color, but I think we can still make this work. From low power, I think there's a lot of similarities to what we were just looking at, right? We've got the epidermal hyperplasia with the tabling of Reedy. It's even got a little Gren's, if you like that. But look, it's irritated in the middle. Gren's goes away, right? And it gets real thin. See, that's what happens. You got nice collagen trapping. Look at that. And this was on, if I recall, like the leg of a 30-year-old woman, I think. something like that. And so we've got collagen trapping, the middle's kind of fascicles or story-form kind of pattern, kind of haphazard pattern like a DF would have. But you're probably seeing by now, what's all that big, dark blobs of purple in there? And oh my goodness, that's pleomorphism like crazy, right? Mm-hmm. Not just a little pleomorphism, that's a lot. So when we have a dermatofibroma that has scattered bizarre nuclei, people have kind of referred to those as dermatofibroma with monster cells. I do not ever put that in a report, with rare exceptions. When I used to do consult cases, I would sometimes tell people that these have been referred to, but I don't ever want that on a line diagnosis and the patient to read it and think, well, no one wants a monster in their body, right? That's just not something people are interested in having, at least. But I think when you see those scattered in an otherwise normal DF, then that's a DF with monster cells, which I personally just sign out as dermatofibroma, and then I point out to the residents, oh look, it's a monster cell, and then I call it dermatofibroma. Next case. Now this is too much for that to me, and how much atypia is too much is to me kind of subjective. But when we have atypia that if you took a high power field here, you could easily say this is a sarcoma, right? This is like got the degree of atypia and pleomorphism and cellularity that you would see in many pleomorphic sarcomas, And then the other thing, if I can find it again, I saw it earlier.
Right there.
Yeah, right there. Look at that. That's like a figure 8 mitosis. That is definitely not normal, no matter what way you look at it. That is an atypical mitosis. So I already told you, dermatofibromas can have mitoses, sometimes kind of a lot of mitoses scattered throughout. But now we've got a lot of atypia, really diffuse atypia, plus a lot of mitoses and atypical forms. I looked around in this earlier, there are other mitoses here. So what are we going to do with this? Are we going to say that this is sarcomatous transformation of a dermatofibroma? Well, no, that does happen. It's very, very rare, but the times that happens, what I expect to see is like a DF that's benign, and then a huge sarcoma, like the sheets of sarcoma growing out like down deep into the soft tissue or something from a pre-existing, like I saw that once before, like on a guy's, it was a lower leg actually, and he had a lesion there for like 20 years, and then suddenly it expanded rapidly, and microscopically there were zones that looked just like a benign dermatofibroma, and then away from that, growing out and invading the adjacent tissue, was clear high-grade sarcoma. So that is one of I've only seen a handful of those in my entire career. Very, very rare to have malignant transformation of DF. And considering I see DFs, every day. So if you're a patient watching this, don't freak out. I've got a dermatofibroma on my leg that I've never had removed. So that's how much fear I have about this, like none. It's such exceptionally case reportable, basically. But this, I think, is a unique situation that people have referred to as atypical fibrous histiocytoma, basically atypical dermatofibroma. And the idea here is that even though these look really wild and ugly up close, if you go to low power, they have all the other features that are basically characteristic of dermatofibroma. And so because of that, and they have a very good prognosis. There have been reports of a small number of them that have metastasized, but just like other dermatofibromas, cellular and aneurysmal, big DFs, every once in a while one of those will metastasize, like to the lungs, and can cause mortality. But we don't go reporting those as like, oh, this could be malignant, because it's very, very rare for that to happen. So one of the kind of landmark paper on this topic by Chris Fletcher and colleagues, I'll put a link in the video down below, it has, I think, really nice criteria for how to approach these. But the way I conceptually think is this looks like a DF at low power, it fits for a DF clinically, and then you go to high power and you see really ugly cells, and but they're in the arrangement of a DF, and it's a small lesion, usually confined to the dermis. If it starts getting down to the subcutis, I start getting more anxious about it, okay? So, and I think in Chris Fletcher's paper, maybe some of them did go in the subcutis, but still I start getting a little more worried. Now, if you're watching this at home, your first question may be, why is this not an atypical fibroxanthoma / pleomorphic dermal sarcoma, right? AFX PDS. Well, I suppose people could make the argument that that's what this is. And I think in some old literature that probably some things that were called AFX on the extremities of young people, in my opinion, were probably not AFX. They were this. In my thinking, AFX and PDS are almost exclusively in old sun damaged patients. And the vast majority are on the head and neck of old sun damaged people, okay? That's the kind of place where if you put a tumor that looked like this, in the scalp of an old person, and I did stains to rule out squame and melanoma and stuff, then I would call it AFX or pleomorphic dermal sarcoma if it was big and went to the subcutis. On the extremity of a young person, I personally am never going to make a diagnosis of AFX or PDS, because to me, the pathway of that is a chronic UV exposure that drives those, in my belief. Now, there may be others that disagree with me, and you're welcome to do that and to go read about other thoughts on that. But to me, on the extremity or the trunk of a young adult or even middle-aged adult, I'm not going to call something AFX or PDS unless there's a bunch of sun damage in the background. So anyway, that's my thoughts on this. Although management-wise, I think you approach the same way. It needs to be excised with a negative margin. This is what I usually recommend when I have had these, but that the prognosis is very good. So that's kind of my approach. And actually, I'll try to remember to put, I have an example of a template of how I've worded these when I've signed them out, because understandably, this is quite confusing for treating physician colleagues to wrap their head around, because you're like, well, you're saying it's like a DF, but then you're saying that that it's got a lot of atypia. It's kind of weird, and it's hard for people to conceptually deal with these, especially the fact that they can have atypical mites and be really wild. And some people have said, well, how do we know it's not a sarcoma that just behaves well because it's small and in the dermis? That is a very legit thought. I mean, it goes into the very deep philosophical questions of how do we define cancer? How much does something have to metastasize for us to, call it cancer? Like, it becomes very complicated, and I don't know the full answer. But I remember the first time I saw one of these in fellowship, and I thought that there was no way this could possibly be any variant of dermatofibroma. This had to be sarcoma, because it was so ugly. So if it startles you and shocks you, hey, I'm right there with you. So in this one, actually, look at these kind of dense keloidal collagen. Another feature that you can see in dermatofibromas. Some dermatofibromas have this kind of collapsing keloidal collagen where they'll get hemosiderin and these keloid-looking collagen, and they all kind of squinch together like this. And so again, another feature that is very typical of like a regular dermatofibroma, but here we're seeing it with the background of a ton of atypia. So to me, once it starts looking like this is when I would call it atypical FH. And I don't have a dermatofibroma with monster cells handy, but basically imagine one of these cells kind of scattered in an otherwise bland-looking dermatofibroma. That's what I would say, just DF with monster cells, which I don't even bring up or mention. So,
are those lymphocytes in the background?
Probably so.
And are they typical?
I don't know. Lymphocyte atypia is something that's out of the realm of my abilities. I think it's like magical, mystical stuff that only hemopaths can do. You know what I mean? But in all honesty, I would say that probably many of the bigger cells are part of the tumor, and they're kind of the whatever a fibrohistiocytic cell is, which is kind of a made-up word that we use for things that have this spindly, slightly histiocyte-looking appearance. I think the very small ones are probably lymphs, and to me, they look normal in size. If you want to find some crinkly cerebriform look, you can always find it, I think, or at least I feel like I can always find irregular like shapes, but nothing really stands out to me as too abnormal there. And I noticed there's some plasma cells here.
Yeah.
See a few of those. No, another one of those big prophase mitosis, right? Where the chromosomes are all, if you're not sure how to tell prophase means that the chromosomes are all arranged into chromatids, so individual little blobs or linear structures of chromatin, and there's no nuclear membrane. The nuclear membrane is dissolved, which tells you that mitosis is already starting to happen. So I think prophase, the kind of spotty, speckled-looking mitoses, are sometimes the hardest for people to recognize when they're starting out pathology, because they don't have that little caterpillar, the little line, or the two parallel lines shape that you see in metaphase and anaphase mitoses. So the prophase ones, I think, good to recognize. And when they're big like that, I mean, that's got to have an abnormal number of chromosomes, right? So something's going on here. I don't know molecularly what's actually happening in these, but and then look, just like regular DFs, hemosiderin. See, so it's got so many of the features of DF. It's actually a little easier to see on the screen than here with the refractile golden hemosiderin, which is a common feature in dermatofibromas. Oh, there's more up here and there. All right. Atypical fibrous histiocytoma. Now here's a big pink bundle. What do you think this big pink bundle of spindle cells is?
It looks like a huge nerve.
Good. Yeah, big pink fascicles of spindle cells. Dr. Rowe, one of my greatest mentors in surgical pathology, taught me there's three things. He always liked to teach three. He said it's either nerve, it's smooth muscle, or it's dense regular connective tissue, which is tendon, fascia, ligament, like we saw earlier with the ramen noodle sign. So nerve, people like to talk about nerve and neural lesions as being wavy. And look, this is a nerve, right? And it is wavy, but look, this is like gently undulating. That's the word I like to use. Look, it's up and down, big waves, like the wave of the sea. Not like the crinkly ramen noodle stuff we looked at earlier. The other thing, and perhaps the best and most helpful thing, is that when you see something that you think might be a nerve, and it's like a normal nerve, not talking about tumors, and it's this big, a big massive thing. I'm on 10x subjective here, and this thing takes up, a decent bit of the field. This is probably like it's probably like I guess it's probably about half of a millimeter or more wide. So pretty small, I guess, in the grand scheme of things, but for a microscope, it's a pretty good sized nerve, right? When a nerve's this big, you should be able to see some myelinated axons, all right? So that's the thing. Little tiny nerves in the dermis, you often don't see any myelin, so it can be harder to tell those apart from other things. Here, usually the myelin's a little prettier. This one's like kind of a little bit bubbly, but you can see all the little areas there. Usually it's a little bit more crisp than this and not so bubbly, but you can see all the myelin there in those nerves, and usually you'll actually see like the little axon in the middle and the vertical incisures of Lanterman Schmidt and all those features that you see in normal nerve. And then you also see nice perineurium around it. See, there's a layer of perineurium wrapping around the nerve. All right, so we've got nerve. And then we've got this little nodule here. So what do you think about this? What is this?
It seems to be a big nodule that's composed of smaller nests of tissue of nerve origin, I would say.
Yeah. Yeah, each one of these, I like I mean, they're not really nests, but they certainly do look like a little nest, like a little ball with a little space around it, right? But when we look close, each one of those looks like a little tiny nerve, not like the big myelinated nerve we just saw. These look like the little tiny nerves that you find in the dermis. Like you could put any one of these in the dermis and that'd be like a totally normal little intradermal nerve. And you can see in longitudinal section how they kind of run like a nerve, right? And they're kind of gently wavy, gently undulating, if you like. And I like that. Oh, this is so nice because nerves often do this. Nerves, especially the little ones, I feel, you'll often get that cleft-like space, even in a normal nerve, that separates the nerve away from the little perineurial layer around it. And oftentimes it gets a little bit of a blue myxoid or mucin substance. You can see it even here. Like, look, there's a little tiny bit right there. I find that actually really helpful if I'm struggling to identify if a little tiny pink structure is a nerve. There's often a little bit of blue mucin or myxoid, whatever name you like. In dermatology, trained people like to call the blue stuff mucin, and soft tissue folks call it, or surge path people call it myxoid. Hyaluronic acid, right? Glycosaminoglycans, whatever name you like for it. It's the little blue goo, okay? And you often find that floating around nerves and in the middle of nerves. And when nerves get inflamed and irritated, I feel like you tend to get more of it even. So what we've got is a million little tiny, maybe not a million, but like thousands of tiny little nerves of varying size. And they're all crunched up together here in a big tangled nodule. And what's in the middle of that nodule? A really big nerve, and this looks like the nerve we were looking at earlier, right? It's a big nerve bundle, and it's even got a thick layer of perineurium, probably thickened because it's an unhappy nerve. And this nerve is kind of growing out, and then what? It's like a Medusa head, right? It's like got all these little nerves coming out instead of hair, you know? And that is what has happened here, is this nerve has been cut and then tried its best to regrow and reconnect to its neighbor. But this was, I think, probably an amputation stump. So there was no neighbor. The other end of the nerve is gone. It's in the surge path lab, right? And this poor nerve tried to regrow and never could find the other end to connect with. And so it tangled itself up into a coiled mess. And that nodule of damaged nerve with tangled little regenerating nerve bundles and sclerotic scar tissue in the background, that's characteristic of a traumatic neuroma. So this is a great example of what traumatic neuroma should look like. And I feel like the best times you see them is like at amputation stumps where they've completely severed a really large nerve. That's the time. You can see it in a lot of different settings where there's been injury or surgery, but I feel like the times where you see it most dramatically is when there's been big, huge nerve cut with a very, significant damage to the nerve, and then the nerve has had no place to regrow. But it's good to recognize, because sometimes, if you're not thinking of it, you could get this confused, with like a neurofibroma. that could look a little like the shredded carrots of a neurofibroma. And every once in a while, I've seen times where there was not a clear history, and this started coming up. And there was a time where I saw one, and the person had a supposed history of a plexiform neurofibroma. And then the question was, is this part of the neurofibroma, or is this actually a traumatic neuroma? And it took tracking down some history to figure out the whole story. So in any case, occasionally this can be problematic, and but this is what they look like. So that's a good example of a traumatic neuroma from a damaged nerve.
So if a nerve looks like gently undulating fibers and fascia looks like instant ramen noodles, what is smooth muscle?
Smooth muscle, that's a great question. Let me see if I got any right here to show. Actually, hold on. Let me look. Okay, look. Here, we found one. This was an unusual pilar leiomyoma that had atypia, but otherwise looked benign, kind of an unusual case. But this is the kind of fascicle pattern that you see in smooth muscle, both normal smooth muscle, and so these are kind of recapitulating a rector pili muscle. This is a pilar type smooth muscle tumor. And the cells usually don't have much waviness, although sometimes they can. I've seen exceptions. I've seen ones that got squiggly and wavy. And the nuclei have those elongated cells that are smooth and rounded on both ends usually. People, say cigar-shaped cells, right? And the other thing I find really helpful is that you look all of the pink here is due to the contractile filaments inside the muscle cells, right? And it's not actually collagen. A lot of the other stuff, the pink we're seeing is some background collagen, particularly like in dense regular connective tissue. Whereas in smooth muscle, the pink is all like contractile actin-desmin filaments and other contractile filaments. And the color is quite different than like collagen. Look at the dermal collagen at the top, how bright pink that is up here, and the kind of paler pink color of the smooth muscle. So that, with practice, you can begin to tell. And again, ignore the atypia here. That's a little complicated and outside what we're talking about. But you can begin to tell smooth muscle from collagen from nerve. And in the dermis, if you see something this big, it's almost certainly going to be a bundle of smooth muscle, right? Because nerves are rarely this big up in the dermis in normal situations. In fact, if we go around here, let's find a nerve for comparison. So sometimes that can be very helpful, is if you're deciding, is it perineural invasion or not, you can, you do want to be able to tell smooth muscle from a nerve because, tumor wrapping around smooth muscle doesn't mean anything. Tumor wrapping around nerve does. So here's a little nerve right here. See that? This is the size of the nerve that we have in the dermis, and the smooth muscle bundles we were looking at were, look, huge compared to that, way bigger. And how do you know it's a nerve? Well, we can look for perineurium. Is one thing we can do.
That's a nerve.
That's a nerve right there. That's probably that same nerve we were looking at up there, which just come down further. Here's more of it, and it's just kind of going back and forth in and out of the section. It's right next to vessels too. So usually when you find the nerve, if you want to find the nerve, go look for the vessels, and in that little bundle of little arterioles and venules, you're going to find a little nerve running right next to it. So that's an example. Okay. So we had traumatic neuroma. Now let's see what's next. So fragments here and some bone. There's some nice concentric lamellar bone that mature bone is made of. And there's a bunch of marrow in between it. And if you're going to want teaching about marrow, you're going to have someone else do it, because I do not know much about heme path and marrow anymore. So bone is challenging for a lot of reasons, one of which is that oftentimes the types of specimens you're getting from bone are these fragmented curettage specimens, right? So it can become very difficult to get a nice view of the architecture because you're just seeing bits and pieces of the lesion. Radiology is hugely important in bone pathology, and really you should always do what you can to get the radiology, or even if you don't have the actual radiographs, to visualize, to see what the orthopedic surgeon thought based on the radiology, to get a copy of the radiology report, because it's really easy to make big mistakes when you don't have the clinical info, the age of the patient, whether they're skeletally mature or immature, what bone is involved, and what the lesion looks like on imaging studies. All can be very, very important in helping make sure. I mean, obviously, what we see on the pathology is very important, but we have to make sure it matches with the radiographic. If it doesn't, then we have to figure out why or get some extra help to make sure. So it's kind of like a way to avoid making mistakes. Is even if the path looks good, if the radiology and clinical doesn't fit, then we have to really step back and ask, am I totally sure that's right? Obviously, there are times where the pathology is more important than everything else, but I always still want to know, and it gives me pause. Just like in the rest of pathology, if it doesn't make sense, you stop and ask, am I sure that this is the right diagnosis? So this is a lytic lucent lesion in the medullary cavity in the metaphysis of the proximal femur of a 10-year-old boy. That's I'm making that history up, but that would be a characteristic radiographic and clinical presentation. And then an MRI would show that this lucent lytic lesion is actually a cyst and that it's filled with water density fluid. And then microscopically what we see is this is the cyst lining right here. And sometimes it can be hard to tell if what you're looking at is the wall of a cyst or if you're looking at fragments of a solid tumor when you're looking at bone pathology specimens, because they're often fragmented curettage specimens. So that's where, again, looking at the radiographic findings and also look at the orthopedic surgeon's clinic note and op notes. They will often have additional information in there. I mean, they're going to know if it was a cystic fluid-filled lesion or blood-filled lesion at the time of biopsy, or if it was solid. So those things are really important to help with a case like this. So the lining is not much. I mean, there's not much going on here. It's kind of this loose fibrous connective tissue kind of forming a band. You can see that you can kind of see that that's really like the edge right here, right? That's the edge of the cyst, but it doesn't really have any lining. It's just kind of compressed like either a thin layer of fibroblasts or histiocytes. Sometimes you can get giant cells along there. It almost, to me, looks like it's kind of doing that synovial metaplasia thing that you'll sometimes see like around, say, a breast implant capsule. It vaguely reminds me of that, but there's not any real true lining. Just a thin rim of fibrous tissue, and in that lining, you often have this dense homogenized pink stuff, and it can run a range from looking like fibrin, like over here, and then here it's beginning to kind of compress and almost looks like it's turning into osteoid or bone. And I'm not actually sure which. I've heard it described as fibrin-like material, but it seems to me to really have a range between fibrin and osteoid, and it like looks very smudgy and homogenized and eosinophilic, and then it begins to transition into stuff that looks more like actual bone. So this is characteristic of a solitary bone cyst, also known as a simple bone cyst or a unicameral bone cyst, although those latter two names are a bit of a misnomer because these are sometimes multiloculated rather than simple, single cystic space. But they're not super exciting to look at because they just have this thin wall. I find the homogenized pink material to be one of the most helpful findings microscopically, and then of course taken in conjunction with the clinical and the radiographic. Let's see if there's anything else going on here. Here's some more over here. See, here's another this is the little thin fibrous membrane that makes the wall of the cyst that we're seeing here. And there can be some blood, even though these are kind of fluid filled. They may have bleeding into them, and as a result, you'll often find little hemosiderin deposits there. Now, if you start seeing a lot of that, you could think, what about aneurysmal bone cyst? Usually, there's going to be radiographic features that help distinguish ABC from UBC or solitary bone cyst, but sometimes they can have overlapping findings. So I feel like the radiology is the most important thing, but then also in aneurysmal bone cyst, and I have a video about that. I'll put a link down below if you're watching this online. There tends to be a lot more kind of granulation tissue-like or fasciitis-like stuff. Now here, there's some right here that looks kind of like loose granulation tissue or almost like nodular fasciitis, but I feel like in general it's much more abundant in aneurysmal bone cyst, and there's also more abundant giant cells. There are usually kind of giant cell rich regions in the lining and walls of the cystic spaces in ABC, and there's lots of new bone formation and like kind of robust reactive osteoid production by reactive osteoblasts. And so those things, I feel like basically that AVC looks a lot busier and more active, and UBC looks a little bit more like bland and boring. That might be oversimplification, but that's kind of the way it strikes me as. Now, I will point out that like many benign bone lesions, cystic or otherwise, they sometimes present when the patient develops a fracture at the site of the lesion. The lesion weakens the bone, and then the kid's out playing or whatever, and he's playing football and feels a pop, and then goes in and there's a fracture with this lytic lesion underlying it. I see benign bone things, and also malignant ones too. I see bone lesions often present that way, where they first show up when they develop a pathological fracture at the site of the lesion. So when that's happened, depending on how long it's been, you can begin to see new bone formation and a lot of the changes like you'd see in a fracture callus in the setting of UBC. So again, that's where the radiographic stuff is important to sort it out. But here's a look again at that homogenized fibrinoid stuff, and sometimes this can make kind of concentric, lamellated, spherical structures that can become calcified, and some people have likened it to the cementum-like material that can be seen in bone lesions of the jaw. Some of those bone lesions, which I find that to be a whole complicated world. That's bone pathology is hard enough, but the oral pathology bone lesions I feel like are like a world apart in their own special kind of categories to me. They're very challenging and complex, I believe. So in any case, this kind of stuff sometimes can begin to mimic cementum, is what some people have said. So thin fibrous lining, that homogenized pink material. Sometimes you're going to get some hemosiderin, and sometimes you'll get some giant cells, although this one doesn't really have much in the way of giant cells. And put that all together with the radiographic information, and you have a solitary bone cyst, aka simple bone cyst or unicameral bone cyst, which is benign. Here we've got like a half of a nodule, it looks like, cut down the middle. This is the lowest power I can get. So what do you think from low power? Like what's going on here?
From low power, I can see that there are some hypercellular and some hypocellular areas.
Good, yes.
And it seems to be formed from spindle cells.
That's right. It is made of spindle cells. And there they are. But I like, in all of pathology, but I think especially in derm path, but also in soft tissue, the low power, you can get some clues, right? Before we look at the cytology, we can look, what is the whole thing homogeneous or is it heterogeneous? Like this is heterogeneous, right? We've got, like you said, cellular areas and then less cellular areas. Is it infiltrative or circumscribed? Well, this has got a nice circumscribed appearance. Here, it's a little hard to tell where exactly we are. Usually, like if this were taken off by a dermatologist or someone in the office, if we have a nodule with nothing around it, probably it's from the subcutis. But if it's taken out by a general surgeon, it could be from anywhere in the body where they've gone in and they've kind of peeled it off. Depends on, and I can't remember this one where this was from actually. But seeing, the size, the depth, how it interacts with the rest of the tissue, and then kind of how the cells are arranged in here, all can give us some clues about which way to go with it. So these are kind of all haphazard spindle cells, right, in this loose background. But then what about the more cellular area? What are the spindle cells arranged like here?
So the nuclei seems to be palisading, like parallel to each other.
Good. And in this area, that's pretty subtle, but you can still, with practice, pick up, look, draw a line here, and there's most of the spindle cells are kind of arranged along that line, like if they were like shish kebabs on a skewer, right? Like they're skewered all right here, and then there's a space of pink without as many cells. Then there's kind of another little zone or band of cells that are kind of parallel to each other. It's pretty subtle, right? A lot of times, junior residents, I'll tell them, and they're like, "What? Palisading?" They don't believe me. But you believe. You've drunk the Kool-Aid now. You believe. And look, oh, there's more. See? That's palisading. But if you don't like that, then let's find the really good palisading. The stuff that the books have. That's what people want to see. That's a little bit more convincing, huh? Like that's a line right there. That's a palisade. So, okay, so what do we call these structures?
We call these Verroque bodies.
Yeah. It's nice parallel palisaded nuclei. And of course, the diagnosis is
A Schwannoma.
yeah, Schwannoma, or old school name Neuroma, if you like. I just call them Schwannomas. But that is one of the most classic features, right? Is hypercellular Antony A, hypocellular Antony B, and then nuclei arranged in palisades with those nice Verroque bodies. But the thing is that in real life, sometimes the palisading is not really obvious. And so recognizing the other features of Schwannoma is really important because it can get you out of trouble, especially if you get like a core needle. So that's sometimes happens because the retroperitoneum is a pretty good site for Schwannomas to grow, and they can become quite big there. I've seen them like 10 centimeters or larger, and they can grow for a long time. And as they grow and kind of get older, this is the theory at least, they can get some weird changes, which we call ancient change. And some of those are cystic blood-filled spaces, sclerotic hyalinized collagen, and big scattered degenerative nuclear atypia, ugly pleomorphisms scattered about. Oh, look. So this one doesn't have the sclerosis and blood-filled spaces so much, but it does have the scattered, what we term degenerative atypia or ancient kind of atypia. Whether it's really time that causes this or not, I don't know. It's a nice story, though. That's what we all say, but I have no idea if it really is what happens. I do think those retroperitoneal ones probably tend to be there longer because they grow bigger before they cause symptoms, and then they have been sitting around and bleeding into themselves, so it does make sense they get some change. But you can see scattered pleomorphism, this degenerative, hyperchromatic, smudgy pleomorphism in any schwannoma, and in fact you can see it in other nerve sheath tumors too. Neurofibromas tend to have this sometimes, especially in patients with neurofibromatosis 1. They can get some pretty bizarre scattered atypia, and then you can think about there are times where there's this kind of intermediate thing between neurofibroma and malignant peripheral nerve sheath tumor that's called atypical neurofibromatous neoplasm of uncertain biologic behavior, I think ANNUBB. I can't remember the abbreviation. I'll put the link down below. In any case, in NF1 patients with a lot of atypia, there are papers about this and about what you should look for and how many mitoses are allowed and all that stuff. It's kind of complicated. But I actually have a video about neurofibromatosis and low-grade MPNST, and it talks about it to some extent in there, and then also a video about regular, typical high-grade MPNST. So if you want to explore that, you can. But the more important thing is that scattered atypia is seen in many nerve sheath tumors, and it's totally benign and indolent by itself, okay? It does not mean anything bad to see scattered pleomorphism in an otherwise characteristic schwannoma or a neurofibroma. Even, you can see them in granular cell tumors. So that's the thing, is degenerative atypia is a common feature in nerve sheath tumors. All right. And so finding scattered atypia in a background of cells that kind of look like Schwann cells or neural cells is actually really quite helpful to support schwannoma. Finding the loose areas, the Antony B areas, are helpful. These areas to me look sometimes almost like neurofibroma. They get a little bit of that almost shredded carrots of pink collagen floating in a loose edematous kind of white background, and more haphazard cells. So I find that stuff is pretty helpful. And there's back to the Antony A. See, look, if you just had that, you might not, there's vague palisading there, but it's very vague. Very, very vague. You could potentially get concerned about this, right? Mm-hmm. So look, that one's got a big pseudo-inclusion, a nuclear pseudo-inclusion. All right, and then look out here. Big, thick, fibrous capsule, right? So the capsule is a pretty common feature in schwannomas, because a schwannoma, kind of the idea is it grows inside a nerve usually, right? It's arising off a nerve, and it grows and pushes the perineurium outward, and then that gets kind of fibrotic. But if you'll do like an EMA or a GLUT1 or a clot and a perineurial marker, a lot of times you'll find kind of layers of perineurial cells in that dense sclerotic stuff. You don't need to do that, but anyway, it's there. And then the other thing is this, hyalinized vessels. I find that really helpful, and it's usually present sclerotic homogenized collagen in the vessel wall. Sometimes it can be very extensive. Sometimes also the vessels leak and they get blood and blood around them and hemosiderin, and they also will get bright pink fibrin in the vessel wall and around the vessel. So you'll have sclerotic collagen and fibrin kind of layered around vessels. And those ones that get really bloody and have a lot of vascular changes, I find they really confuse people, because the blood and the cystic formation really makes people think of like vascular stuff and other things, not schwannoma. So I don't have a good example of that handy to show. But in any case, those are all features you can think of. And there, that was the best. I mean, that's what the textbook shows, because everyone wants to see that, right? Because it's pretty and it's really easy to recognize, and even med students, we teach them. But when you don't have that, if you don't know those other subtle features of Schwannoma, you can be in trouble. And I did say if it looks Schwannian, well, cytologically, there are a couple clues to Schwann cells. Let me see if I can find some here. But I do find if you have, the thing that I think is some of the hardest things to tell apart is fibroblastic proliferations and neural proliferations. The cells and kind of their arrangement can look very similar. There are a lot of fibroblastic things that can mimic neural things and vice versa. Like, for example, dermatofibroma protuberans, which is kind of like a fibroblastic type of derivation, we think. It can look a lot like diffuse neurofibroma, and there are many other examples like that. So if you struggle with that, I do too, and I find that that's where S100 or SOX10, a neural marker like that, can be very helpful in sorting out neural lesions from fibroblastic. So Schwann cells tend to be shaped, they look a little different at one end than at the other. Now, that not every Schwann cell will do this. Let me see if I can find a good example. I should have looked this up and marked it before. Okay, so one pattern is this. See this cell right here? Look, it's got like a flat line on one side, and then the other kind of a rounded edge, kind of like the shape of a bullet, right? A bullet, flattened bottom and rounded top. Other times, the bottom is kind of not as flat and is more rounded, and they look kind of like a sesame seed, like you put on top of a bun to have on a sandwich. And so I don't know if I've seen any real good sesame-shaped ones here, but sometimes they are like pointed on one end and rounded or blunted on the other. And Mark Edgar taught me that, one of my great soft tissue mentors who had so many great visual clues for diagnosis. The other thing that Mark taught me that I found really helpful is this. Schwann cells like to be in pairs, like partnered up end to end, where you have one Schwann cell and then here's another. There's actually like maybe 3 or 4 right here, but see how they're in a little row and the blunt ends butt up against each other, right? Like you took 2 bullets and put the flat side back to back. And hopefully YouTube doesn't ban this for talking about bullets, but in any case, I'm not advocating anything. I'm just trying to make a visual reference. Okay, so there you can see them though, where they touch, right? You have like one and then another one touching right against each other. So there, I admit it's very subtle, but sometimes those subtle things, seeing the little chain of nuclei, the flat end and then the rounded end, can really make me think, ooh, maybe this is neural, if it's a hard case. The other thing that they do is they sometimes have like kind of an S shape or a bent or buckled or crooked shaped nucleus. And I'm trying to find a good one of those. So that one, right? It's not perfectly straight. It's kind of curved a little bit like a boomerang maybe. And sometimes they're curved even more, like kind of if you took the top of a can of, soda or Coke and you popped it, that little tab that you pop, instead of it being flat, it's bent in the middle. And I think a lot of times Schwann cell nuclei look that way. I think you see the nuclear feature actually a little bit better sometimes in neurofibromas because they're a little bit more loose and spaced out and not packed together like they are in Schwannomas. So maybe next time you see a neurofibroma, go look around and see if you can find some of these cells. Because once Mark had told me that, I started looking for it, and I was like, oh, it's totally, that really works. Those features are there more often than I realized, and I just hadn't been looking for them. So anyway, we've now dove really deep in, and I do have a full-length video about Schwannoma, although I've talked about this one long enough that it's going to probably approach the length of that video. But if you want to learn more about nerve sheath tumors, I'll put links in the description down below. And there you go. So Schwannoma, benign and beautiful, although they can be painful sometimes because they come off the nerve. All right. Now this is one, I do have a scan of this somewhere. I'll have to pull that out and post it because it's so much more dramatic when you can see the entire lesion from low power. And this is 2x, is as low as I can go. Hey, wait, what's this structure right here? Look at that, ramen noodles. Yeah, that's dense regular connective tissue. That's collagen, not nerve, right? Good. So where do you think we are here? What is this?
That is synovium.
Very good. Synovium looks almost like an epithelial layer, but it's not held together very well, right? It's like if histiocytes all got together and kind of made a half-hearted attempt at making an epithelium. That's what synovium looks like to me. They're kind of got pink cytoplasm like histiocytes, and they're packed up together and making a layer, but it's not a tight layer, right? Epithelium is supposed to be nice and tight and keep stuff totally confined, and these guys are just kind of like hanging out together, like kind of loosely, right? They got space between them. So I feel like that's how, if you're a beginner, that's kind of how I recognize synovium, is it's a lining of cells that have rounded nuclei, but they're nowhere near as organized as a real epithelial layer would be. And that's because these are not really an epithelium. So we do have a synovial line space. So that means we're either in a joint or, you know, a bursa space could look like that. But given this big, huge slab of tissue here, I'll tell you right now, we're in a big joint, right? Mm-hmm. So what would you make of a lesion like this? It
looks like a mature adipose tissue.
Yeah. And there is adipose tissue around the joint as well as fibrous tissue, but this is like pushed into the joint, right? With these multiple polypoid shapes. So this thing is an unusual beast, a good kind of beast, not a bad one. It's called Lipoma arborescens, or I think the other name people use is synovial lipomatosis. This basically is benign fat that's pushing up and making these polypoid projections into the synovium, and on intraoperatively, oftentimes these have a polypoid protrusion into the synovial space, and grossly also can have like kind of frond-like looking appearance. And I have seen these in conjunction with other things. Like I've seen people that had pigmentonodular synovitis that also had synovial lipomatosis or lipoma arborescens, like kind of tree-like, branch-like lipomatosis, excuse me. And then I think I've got another piece from the same case. Oh yeah. So again, just to show the polypoid configuration. And then also when you see polypoid projections of synovium without a bunch of fat in them, you can also think of a papillary synovial hyperplasia, right? Reactive hyperplasia of the synovium, like you can see in, you know, around osteoarthritis or other reactive conditions of the joint. You sometimes see polypoid projections that are just a reactive process there. So that's another thing that can give you polypoid projections of synovium into the joint space. Kind of cool to look at though, right? It's like this big protrusion of fat lined by synovium into the joint. I mean, look at how big that is. Big, huge nodule. Pretty cool. Lipoma arborescens. Okay, so here's what the whole slide image looks like. Pretty amazing, huh? I told you it was awesome. And you can see the massive polypoid projection into the joint space and kind of that frond-like growth here. And I'll put a link down in the video description so you can go check this slide out for yourself online. And I forgot to mention when I was talking with Fatima that you often see a lot of dilated vessels in the adipose tissue, as you can appreciate here, in Lipoma arborescens, and also you can see some mixed inflammatory cells as well. So make sure to go check this slide out so you can explore it for yourself. So here's another lesion that was from a joint. You can tell right away it's made of
cartilage.
Yeah, beautiful, beautiful blue hyaline cartilage. That color is fantastic, isn't it? Sometimes you get lucky and the cut and the stain are just right and the cartilage just looks amazing. Other days it doesn't work out so well, it just depends. But this one worked out. And I think part of why it worked out is a lot of times when we see cartilage, it's in bone and it really messes up the sections. We got a couple folds there. There are some little bits of bone here, but this was actually a lesion in the soft tissue and the synovium right around like the knee joint, not involving the bone. But that goes back to what we were talking about earlier. It's always important to know the radiology, especially if you see bone or cartilage in a lesion. The next thing I want to know is this lesion arising on the top of the bone or growing out of the underlying bone, or is it purely in soft tissue away from the bone? Because a lot of times that's going to really change the way I approach a case. For a bone producing or cartilage producing lesion, there are different considerations and different things that I'm going to think about and say in my report based on whether it's in the bone or not. And sometimes you don't have that information, and there have been times where I had to say, well, especially like I feel like I see that often like in the fingers or toes, where someone will go in, they think it's a little soft tissue mass, they scrape out some pieces, I see some bone and cartilage, but it's not clear to me if this is arising totally in the soft tissue, if it's growing off the outer cortical surface of the phalanx bone, or if it's actually they're down in the bone, and unless you have the operative note or imaging studies, you can't always tell. And I've occasionally had to say, well, here's what I'm seeing, and it's really important actually to find out if this is in the bone or not, especially if it's a consult or something and you don't have all the history. So those are always uncomfortable things to deal with. But here, I'll tell you, this is not in the bone, even though it is producing a little bit of bone. And it's not been decaled. That's why, without decalcification, that's why the bone's very purple and fractured. And you can see where the bone's coming from. The cartilage itself is actually ossifying, right? You get a nodule of cartilage right here, and it's beginning to produce some bone. And that happens sometimes. Cartilage lesions have a tendency to get calcified and ossified. All right, so from low power, though, we've got a big, huge mass of cartilage here. But also we got, where is it? There. Multiple little kind of discrete islands in a background of reactive kind of fibrous and myxoid tissue. So what is this? These multiple islands of cartilage that are benign appearing.
This condition is called synovial chondromatosis.
Very good. This is synovial chondromatosis. One thing that helps me is that I've got multiple little islands like I showed you from low power. The other thing is that when you get closer, the cells do the kind of same thing. They cluster into these little proliferative islands or nodules or kind of clonal islands. You can see some of this kind of clustering in reactive cartilage like in osteoarthritis, degenerative joint disease. Occasionally you can see that, but I feel like it's the most dramatic in synovial chondromatosis, these little proliferating clonal nodules of chondrocytes. And it's a little hard to be able to see the nuclear features because the background matrix is so blue, it often obscures, but I'll try to get it in focus here. And sometimes chondrocytes, their nucleus turns into like a little dark purple dot, and you can't even see the nuclear features at all. But here we can see them, but they've got little tiny round or maybe some occasionally bean-shaped little bland nuclei sitting in those little lacunar spaces. Pretty awesome to be able to look at up close here. So even though it is more cellular than a cartilage tumor like inside the bone would tend to be, in this setting that cellularity doesn't bother me at all personally. So that's synovial chondromatosis. And it's got some calcifications there in it. And then I also think this like reminds me of like the surface of an alien planet or something, like dried up riverbeds in the desert, you know. If you have a good imagination, you can make something out of this. They make wallpaper, I think. That's pretty cool, right? Okay, maybe I've been doing this too long. Here we go.
If you have like wet paint on silk.
Ooh, yeah.
Salt grains on it, then the salt absorbs the paint from it and sort of creates these halos like.
And it looks like this?
It looks like this.
That is cool. We're going to have to, do you have some of this artwork that you've done at home?
I did it in grade school. I don't have it, but I can find
someone
it.
At home, if
Yeah.
you're watching this online, please post a picture of your artwork or post a link to it in the comments so we can see the silk painting. That's pretty cool. I don't think I've ever done that, but that sounds really awesome. I thought you were going to go with the direction of like the, when you pour the paint, the dirty pour where they pour the acrylic on the, like I've got a couple of here from that Dr. Eva Wojcik from Loyola has kindly donated to my collection, and it reminds me very much of this. So anyway, all right, well, we've talked about it enough, but wow, if you don't like this, I don't know. No one's going to still be watching this video after an hour if they don't like this. So I think everyone who's left watching the video, they'll find appreciation. All right, last case. We'll call it a day. Well, here's a big nodule. Shelled out from somewhere. We don't really see much normal tissue around, do we?
Mostly fibrous tissue.
Yeah, it's been cauterized there at the edge. Oh, there's a nerve.
There's a nerve.
There. Oh, that's what I wanted to show earlier, how nice that was convenient. Even though it's a bit cooked from the cautery, you can see the pink dots in the middle are the axons, and the white space is the area where the myelin used to be. Good. So now over here, I guess let me go back up to lower power again. Inside this big nodule, we've got kind of multiple smaller nodules, right? Packed close together. Lots of big dilated blood vessel spaces. Bands of fibrosis or fibrotic tissue in between. And then going closer to one of these nodules, tell me, what does this look like to you, or what do you think about when you see cells like this? Because these used to give me a little trouble when I was a trainee.
This looks neuroendocrine to me. Like the Zelballen look, but here the nests don't have that many cells in them.
Yeah.
Still, it has that look
Little
to it.
balls
Little
all packed
balls.
together. You're right. And that's a great point, that a lot of times those multiple round nest-like structures or balls of cells packed together into a bigger nodule. The Zelballen look very good for, well, what's the tumor it's classic for?
Pheochromocytoma.
Yeah, pheochromocytoma, or if it's outside of the adrenal, paraganglioma, right? Which are basically, in my thinking, they're the same tumor, although there's different considerations depending on where they are in the body and if there's syndrome associated or not, which we won't go into here because it's more complex than we have time for. But we have time to talk about how cartilage looks artistically, but not to go into genetics and syndromes. All right. Maybe this is my problem. Okay.
That's where our appreciation of art comes from.
Yeah, that's right. We have to have a well-rounded, education. So you're right. This one is kind of interesting because each cell ball, so to speak, is one cell pretty much. It's like a massive giant cell there, not multinuclear giant cell, but I mean a very large cell making up its own little ball. You're right. But that same pattern, though, of that closely packing of nests, some people say that these like neuroendocrine tumors look kind of organoid because they look like a bunch of like parenchymal type cells from an organ packed together. That never totally worked for me, to be quite honest, because I was always like, what organ? This doesn't look like any organ. So it took me a long time to understand organoid, but I think that's what people mean, is it looks like a bunch of cells packed together with then like stroma in the background. But that never worked with me. I'll tell you what helped me a lot, though. These cells look epithelioid, right? They have round to oval nuclei, abundant cytoplasm, and they're kind of arranged in nest-like structures where they're sticking together, and then even in bigger nodules where they're discretely separated from the surrounding soft tissue. So I used to always struggle when Dr. Rowe would show a case and I'd say, I don't know what this is. Like, it's paraganglioma. And I was like, So what I finally started thinking is if something looks like an epithelial tumor, but it's in a weird soft tissue spot, I would think of paraganglioma. And I started being able to recognize it because of that, because you're dealing with an epithelioid thing outside. Although of course, there are many other epithelioid looking tumors, but people don't often describe this, I think, as an epithelioid tumor. But to me, it very much cytologically looks epithelioid. So they can have a range of features. The nuclei can be very neuroendocrine looking. This one doesn't strike me particularly that way, like cytologically. I guess you could argue it's a little salt and peppery, but I mean, it's not like characteristic, classic. Also, I think a useful thing to remember is that you can get weird pleomorphism in neuroendocrine tumor. Look how big that guy is. Mm-hmm. And it's like a very pale nucleus too. Like, what the heck? But you can have very large nuclei and pleomorphism, and as far as I understand, that does not predict how the tumor is going to behave. We know a subset of paragangliomas and pheochromocytomas can metastasize and behave in a malignant fashion, but we don't have a good way to predict which ones will. Sometimes, based on the site they're at, like I think the ones in the adrenal have a higher tendency to be more aggressive than the ones like I think in the neck, and this was from the carotid body in the neck. So the so-called glomus jugularis, which is not actually a glomus at all, it is actually a paraganglioma. So usually these are diagnosed before operation. They take these out, but they've already diagnosed it based on the clinical and the imaging, and sometimes they'll come out too partially infarcted because they'll have done, some injections to try to occlude the blood flow and sclerose it off, like interventional radiology and stuff. So in any case, this is a good example, though, of the weirdness that you can see in the nuclei. They tend to be positive for neuroendocrine markers, right? The other thing is sometimes people like to do is the S100 to highlight the sustentacular cells, these little smaller cells that wrap around each of the Zelballen. And when it works, it looks really pretty. Although I've seen some where it was disappointing, let's say, where I clearly knew it was paraganglioma, and I was like, let me do it for teaching. And then I thought, well, it's there, but it's not as beautiful as the books show. The other thing is that usually these are keratin negative, but occasionally they can have some keratin, and that can become a problem because keratin plus neuroendocrine markers, you start thinking about things like carcinoid tumors or low-grade or well-differentiated neuroendocrine carcinomas or neuroendocrine tumors. The names have been changed multiple times since I was a resident. From other sites of the body, you might start thinking about now. If it's here on the carotid, well, you know that it's got to make sense to be a paraganglioma. But in other sites in the body, in unusual sites, you could really start struggling with thinking, could this be a metastasis? And in fact, one thing that's really important, and that thankfully Dr. Weiss mentioned to me one day just during sign out when I was her fellow, and I'm so thankful she did because it saved us in a case in the future. She said that particularly when you get paragangliomas that arise near the sacrum, they tend to have a lot of keratin expression. So they can be strong and diffuse keratin. And I saw one once where the initial pathologist thought that it was actually metastatic neuroendocrine carcinoma, like from the lung or somewhere else, but it was near the sacrum. And then after it was reviewed and we looked at it, we figured out no, it was actually just a paraganglioma that had a lot of keratin expression. And so that made a big change for the patient, right? It was a primary tumor that was most likely going to be indolent rather than a stage 4 metastatic tumor. So hopefully that'll help you out there. Just remember that sometimes, and I did look after that because I've seen them occasionally, at least once or twice at other sites that had some keratin, and I did go do a look in the literature and found that occasionally, it's not common, but it can happen, that in other sites, even the ones in the carotid area can sometimes have some keratin expression, although the other one I saw was kind of focal. It wasn't very much keratin, but so it can happen sometimes. So, and the one other thing I think that you should keep in your differential for these that is not often taught is alveolar soft part sarcoma, because they can have cells that are big and round like this and have abundant pale pink cytoplasm. And when they are, the classic ones have big open nests that have falling apart in the middle and discohesive and have that alveolar look. But they often have areas that look very much like this, that look very Zellballen. And especially when you have big cells like this, definitely think about that. And I've seen ones that had very little alveolar architecture and were mostly composed of these little tightly packed nests of large epithelioid cells with pale cytoplasm. I have a video about alveolar soft part sarcoma and also about alveolar rhabdo and how to tell those apart. And you can go and compare this and contrast. And I think I show an area in that video, if I recall, that looks a good bit like this. So that was one of those things that if someone told me that, I don't remember it. But in practice, I've noticed, wow, that could look a lot like an area of paraganglioma, or that could look a lot like ASPS, alveolar soft part. So, and that's a very important sarcoma that unfortunately has a pretty bad behavior a lot of times, and it's really important to not miss it. So a good one to know about. So in any case, be aware of that. And you can do additional stains, like those will stain with TFE3, and they should be negative for the neuroendocrine markers and other things that we have here. So there's paraganglioma. And I don't think this one has any ablative stuff. Sometimes you can actually see the ablation material in it. It depends on what they've used. I think there's different approaches.
And you shouldn't biopsy one of these because it bleeds a lot.
Yes, and I think some paragangliomas are secreting, right? They secrete catecholamines, although my understanding is that that's the ones in the carotid don't tend to do that as much. It's more like the adrenal ones. But also, I think if you go mess around with them, sometimes they can dump the catecholamines in the ones elsewhere in the body, and that can become a real, people can have like really serious problems from the catecholamines. So, all right. Well, I think that brings us to the end. Thank you so much for doing this with me, Fatima.
My pleasure.
And thank you at home for watching. I hope you enjoyed. Have a nice day.